Yeah, good evening, friends. Welcome to the Tuesday evening critical care and emergency updates from Yashoda Group of Hospitals. We are privileged and pleased to bring this updates and debates and discussions to all of you. Today, we have an interesting discussion and debate, which many of us from our medical school days has many questions in mind. That is related to how do we declare a patient brain dead and what are the medical legal links to this brain dead declaration and what are the different challenges we face day in and out. And to actually decode that, we have Dr. Durgesh, who is a senior consultant who is working with neurocritical care for the last half a decade or so, has a vast experience in managing these brain dead patients, declaring them, doing the complex work of managing the families and also managing the legal issues there. And to address further, we have an expert panelist. I can't think anybody better than her in the state of Telangana. We have Professor and Dr. Swarnalatha, who has been in charge of cadaveric transplant program of state of Telangana, and under her flagship, under her leadership, we have seen and we have grown up looking at the organ donation has been taking leaps and bounces in the Telangana, and we have been one of the leading states for that. And we will take her comments over that. And she has been also an associate professor of nephrology added to her credentials in the Nizam Institute of Medical Sciences. So we will take her comments in and her opinion later. So to start these proceedings, we invite Dr. Durgesh to start the brief presentation to take us through quickly what is this Organ Donation Act and how do we actually declare the brain dead and what are the common challenges we face and what are the different legal implications and acts which we came across. Over to you, Dr. Durgesh.
Good evening, everybody. Thank you, Dr. Venkat sir. Thank you, Dr. Venkat sir, for this brief introduction. And I would like to thank you, Dr. Swarnalatha madam, also for chairing this session. I'm briefly discussing regarding brain death aspect, how we'll go ahead with the brain death. It's a legal complication, legal controversies. Then we'll have a discussion regarding the few, what are the controversies. To start with, first death, which is a universal phenomenon as good as.
Durgesh, can we make it full slide? That is a slide presentation.
Yeah, is it good, sir?
Yeah.
Yeah. Thank you. We'll start with our session, today's evening session. Death is as a universal truth that birth is. It is usually defined as an irreversible cessation of all vital functions, especially indicated by permanent stoppage of heart, respiration, and brain activity. Actually, throughout the history, as well as throughout all cultures, the movement of death has been held in great fascination. A living person dying, it is not only a clinical phenomenon, but it has profound clinical, psychological, financial consequences. Considering this, Indian Penal Code Section 46, as well as the Registration of Birth and Death Act 1969, previously gave the definition of death. As per Registration of Birth and Death Act 1969, the death is defined as a permanent disappearance of all evidence of life at any time after the live birth has taken place. And IPC Section 46 defines death of a human being unless the contrary appears from the context. Initially, the brain death concept was first recognized in the ICUs in the Paris. What they found that those patients who are having severe traumatic brain injury or massive intracerebral bleed, they, if putting on mechanical ventilator, they never recovered. So they put a terminology called as coma de pass or beyond the coma. After that, in 1968, ad hoc committee given by the Harvard Medical School gave a consensus definition, a consensus guidelines on the brain death, which has been accepted universally in the medical community. Afterward, in 1981, in the law of United States, the neurological criteria for defining brain death has been included. In 1976, UK included neurological criteria for defining the death. If considering India, the declaration of death by brainstem death criteria has been given a legal recognition in the Transplant of Human Organ Act 1994. The brain death has been intimately linked to the organ donation and is only defined in the Transplant Human Organ Act in 1994. How the brain death happen or how the cerebral death happen. Initially, we have got a neuronal injury. Then obviously there is a neuronal swelling. After neuronal swelling, there is an increase in the intracranial pressure to the extent that it will become more of mean arterial pressure, which is incompatible with the life. And as the ICP goes on progressively, there is a progressive decrease in the mean arterial pressure, and progressively there is a decrease in the intracranial flow to the extent that the patient will land up in the cerebral circulatory arrest. As well as in hypoxic injury, there is a reperfusion injury, which this cycle perpetuates till there is a coning and or there is a permanent irreversible neuronal injury. So coming to the defining how will we say a patient is brain death or brainstem death, there are certain prerequisites has to be followed. In 2010, American Academy of Neurology given the brainstem death definition and criteria as it is a cessation of all function of entire brain, including brainstem. And they gave a component like the irreversible coma. The cause of irreversible coma should be known. There should be absent brainstem reflexes, and the apnea test should be positive. Then going to the cause of coma should be known. Either it may be with hypoxic ischemic insult, or it may be diffuse SIH, or it may be there is severe traumatic brain injury, or it is a significant intraparenchymal bleed. Then we should have a history which is compatible with the neuroimaging. Like the patient might be having sudden unresponsiveness, or the patient, which history helps to differentiate between different kinds, like patient might be having neuroparalytic snake bite. This history also differentiate the confounding factors which may consider in the further examination, like patient might be having brainstem encephalitis, patient might be having GB syndrome, or patient might be having some neuroparalytic snake bite. Then we have to exclude all these drugs. Say suppose patient might be receiving any sedative neuromuscular blocker, approximately 5 to 5 to 6 half cycles of the drug has to be passed. Then we further the effect of drug can be decreased. In case of neuromuscular blockers, we may use a train of 4 response. Hypothermia should be excluded. The temperature of the patient should be more than 36 degrees centigrade, because as the temperature goes down, the brainstem reflexes might be sluggish. Say below 30 degrees centigrade, there may be absent brainstem reflexes. And hypothermia also prolong the metabolism of the drug. So for patient who is subjecting for apnea testing, we should target a temperature of more than 36 degrees centigrade. Hypovolemic shock should not be there. Endocrine metabolic abnormality should be ruled out. Say severe hyponatremia, hypernatremia, different kinds of encephalopathies, hyperglycemic comas, encephalopathy arising from diabetic ketoacidosis, metabolic acidosis. These are has to be ruled out. After ruling out these, then the patient will go for a brainstem reflexes checking. We various brainstem reflexes like motor response we have to check. We have to give a painful stimulus in the cranial nerve distribution, like sternal rub. We have to give a supraorbital pinch, or we have to give a trapezial pinch. Pupillary size, it may be semi-dilated or it may be completely dilated. Pupillary reflex has to be absent. Caloric test has to be absent. There should not be any doll sign movement. various like corneal reflexes, cuff and gag reflexes should be absent. Then if this criteria is met, then we will go for the testing called as apnea testing. Here what we do is we first denitrogate the patient, that is we'll pre-oxygenate the patient with 100% FiO2 on the mechanical ventilator, so that we will achieve a comfortable partial pressure of oxygen. So in case if we are disconnecting the ventilator, there should not be any desaturation. We'll achieve a normocarbia with the existing mechanical ventilator, checking the temperature, euvolumic status, and systolic blood pressure. We'll go for apnea testing. Here we obtain the baseline ABG and we'll disconnect the ventilator and we'll give oxygen through the suction catheter at the rate of around 6 to 10 liter per minute. And after say 8 to 10 minutes, we'll obtain again
Durgesh, your video got muted.
movement during this testing. Will label it as a negative apnea test. If the rise in the CO2 is not up to the mark, like less than 60 millimeters of Hg, of rise is not more than 20 millimeters of Hg, then we'll label it as a apnea test to be indeterminate. Then in this case, we may repeat again apnea test, or we may go to the ancillary testing. During apnea testing, we have to make sure that there should not be any hypotension, or in this case, we have to increase the fluid or increase the vasopressor support, or if resistant hypotension, in sometimes we may have to abort the apnea test. Desaturation also be taken care.
There seems to be a networking issue with Dr. Durgesh.
Yes. Pawan, can you look into it? Yeah, Durgesh, you are just talking about abort test at that time.
Yeah. Then
just revisit the previous 1 or 2 slides. Yeah.
So after confirming there are no brainstem reflexes, then we'll go for apnea testing. The procedure in apnea testing, what we see is we'll pre-oxygenate the patient initially for approximately 10 to 15 minutes to denitrogenate the patient, so that we'll have a partial pressure of oxygen, at least say around 200 millimeters of Hg, so that any further, if we disconnect, there should not be any desaturation. The next thing is that we'll adjust the ventilator settings so that normocarbia can be achieved. And core body temperature should be more than 36.5 degrees centigrade. If euvolumia or any positive fluid balance, we have to maintain. And systolic blood pressure, we have to maintain at least for 100 during testing. Say, we will obtain a baseline ABG, then obtaining it, we'll disconnect the ventilator and we'll deliver the oxygen by through a suction catheter, approximately 6 to 10 liter per minute. And then after say 8 to 10 minutes has happened, we'll obtain another ABG. During this whole process, we have to observe the chest and abdominal movements. Say, and obtaining the ABG, we can interpret the apnea test. Say, if the test is positive, when the CO2 rises more than 60 millimeters of Hg, or rise of more than 20 from the baseline, and there are no respiratory movements, we'll label it as a positive apnea test. If there are any respiratory movements during any time during apnea testing, we'll label it as a negative test. So if the rise of CO2 is not up to 60, or rise is less than 20 millimeters of Hg, then we'll label it as an indeterminate test. Further, suppose if patient is having significant and resistant hypotension, in spite of fluid or vasopressor, will not able to achieve the systolic blood pressure of more than 100, then we may have to abort the test. If patient is having significant desaturation for at least say 30 seconds, if the saturation is like 85% for more than 30 seconds, then we have to again abort this, or patient may develop significant arrhythmias. During that time also, we have to abort the test. In case of desaturation, we may change the pattern. That we can use the TPs, or we can put a CPAP pressure support mode. There also we can do the apnea testing. Say after apnea testing, like certain things which are incompatible with the brainstem death, like seizure or decorticate decerebrate posturing. It has been said that these are originating from cortex. So the patient with having seizure or decorticate or decerebrate posturing, we cannot go for a brainstem death testing and declaration. But certain tests like spinal reflexes, Lazarus sign, or blushing, tachycardia, normal tension, or even if there is no DI, then we can go with a brainstem death test declaration. Certain ancillary testing has been suggested. Say if we are not able to check the brainstem reflexes, suppose the severe orbital injury is there, or severe facial trauma is there, or cervical spine instability is there. There we will not able to, we may not able to test apnea test. In that case, we will going for ancillary testing. Or suppose for panel of doctors, there is some doubt or there is some disagreement among the doctor regarding the diagnosis. In that scenario, we'll go for ancillary testing. The various ancillary testing used are electroencephalography, cerebral angiography, somatosensory evoked potential, transcranial Doppler, PET scans using glucose metabolic studies. But the caution here is that this test has not been included in the Transplant of Human Organ Act, as well as the legal acceptability is challenging. So further, then suppose EEG will see there will be total electrical silence. Then there will be no blood flow in the intracranial vessels in cerebral angiography. If we are using transcranial Doppler, there will be spiking only during systolic flow. There will be reverberation flow during diastole. Ultimately, isolated systolic flow will be followed, and there will be no spike. Then the patient will end up in cerebral circulatory arrest. If you are using PET scanning, then there will be a hollow skull sign or hollow sign can be seen here. Then who will certify the apnea testing? There should be, it is said that there are a panel of 4 doctors should be there. One is like physician who is treating the patient. The physician is representing the treating hospital. It is an independent specialist, or either nominated neurosurgeon or neurologist, and a registered medical practitioner in charge of that hospital, or medical superintendent of that particular hospital. The apnea test has to be repeated at least for after a minimum 6 hours. It has to be like persistence of clinical state, or to avoid any observation error, we have to repeat the apnea test after 6 hours. Then coming to the where different like infant and children's, the duration has to be there. Children's and infant, they are more resilient, so the duration of 2 apnea tests differs. In infants till 2 months, like we have to do 2 apnea tests for at least separated by 48 hours. In the infants, like up to 1 year, there is the difference should be more than 24 hours. Like up to more than 1 year and up to less than 18 years, like more than 12 hours difference should be there. In more than 18 years, as an adult, this test has to be carried out 6 hours apart. Then regarding maintenance of potential organ donor, IFCCM 2017 has given extensive guideline regarding how we'll maintain the patient which are potential organ donor. Like those patients who are subjected, who are like confirmed, or they are like they are impending brain death or significant traumatic brain death, inevitably they will develop hypothalamic damage. The patient might be landing hypothermia or hyperthermia. They may land up in severe vasodilatation. That has to be taken care of. As there is a total there is a cut of sympathetic activity, the patient will end up in severe vasoplegia, hypovolemia. Then that has to be taken care of. So the posterior pituitary damage, the patient might land up in diabetes insipidus. That has to be also taken care of. This patient DIC is very common because there is a release of tissue plasminogen factor in the circulation. And during this during all this phenomenon, there is a profound release of catecholamines, which is said that 1,000 times normal than 1,000 times more normal than the normal levels. Then the patient might have sustained significant myocardial damage, or arrhythmias may also happen. And there is a leaky capillary syndrome might happen in such a patient because of damage of glycocalyceal layer. The patient may land up in pulmonary edema. All these complications we have to day in and day out while dealing with the brainstem death patients. Coming to the hormonal replacement therapy, you had to use a vasopressin if in patient is might be having diabetes insipidus, methylprednisolone in the dose of 15 milligram per kg for 24 hours if we are considering lung as a transplant organ. Thyroxine in the dose or insulin has to be given. We have to maintain a normoglycemia for better organ prevention. Now coming to the second and organ donation in India. In India, the organ donation rate is significantly less. We have got a 0.8 per million population compared to the developed countries. US might be having around 32, or maximum having Spain is around 48 million transplant organ donation per population, per million population. It is said that if the patient is having natural cardiac death, only few organs or only tissue can be donated. Brainstem death has happened. As many as we may donate 37 organs. So, considering this to regulate the removal and storage of transplantation of human organs for a therapeutic purpose and for prevention of commercial dealings in human organs, the act was given by the Ministry of Law and Justice in 1994. It says that the Transplant of Human Organ Act. As per the act, this act has been adopted by most of the state except Jammu and Kashmir and Andhra Pradesh. Both of these states had their own legislature in this regard. Because first time the brainstem death has been declared and it has given a legal recognition in India under the Transplant of Human Organ Act. So in India, in the it has been usually seen that too in the recognized institute where we can able to do a transplant surgeries. So coming to since the Andhra Pradesh has not opted for this act, we have got a separate act called as Jeevandan. That is a cadaver transplant program, which is given in the Andhra Pradesh Transplant of Human Organ Act in 1995. Probably, as per my knowledge, after 1995, there are no amendments in the act. This is the official website of Government of Telangana for Jeevandan Cadaver Transplant Program. You can see here, you can have different activities. You can pledge yourself online. We have got information regarding upcoming activities. We can have information regarding recent donors. We can have information regarding which are the transplant capable hospital, which different organs can be transplanted at different hospital in the cities. Also simple like information regarding few information can be solved if we search on that frequently asked questions section in this site. This we have to fill up this type of form, which is given by Jeevandan. And this is the Apnea test form where you can see the date and time of first testing as well as date and time of second testing. Usually, like I said earlier, it has to be signed by 4 panelists. One of them is a medical Incharge, medical administrator of the hospital. The second one will be the authorized specialist, which will be a nominated person from that particular hospital, independent of specialty. The third one person will be the neurologist or neurosurgeon, and fourth person will be medical officer treating that patient. The next amendment happened in the Human Transplant of Human Organ Act in September 20, 2011. Now, as per this act, initially the 1994 Act, it is only said that transplant of human organ. But Amendment Act is now renamed as a Transplantation of Human Organ and Tissue Act. This is called as THOTA Act 1994. As per this Amendment Act, the what are the changes? The tissue has been included along with the organs. The definition of near relative, they included grandparents as well as grandchildren, apart from previously existing son, daughter, brother, or any siblings. There is a provision of swab donation, and there is a mandatory transplant coordinator in all the transplant capable hospitals. And it has been said that it has to be maintained a national organ registry for donors as well as recipients as well as tissue removals. And there is a prohibition of organ donation from mentally challenged, and you should be very cautious if you are taking our caution regarding case of minors or any foreign nationals. Another amendment which has been given this act is where there is a no neurosurgeon, neurophysician, any nominated surgeon, physician, or anesthetist or intensivist may go for apnea testing. Okay, source of organ donation for the recipients. It might be live donor from a near relative, or it may be deceased donor transplant. Deceased donor transplant after brainstem death or after cardiac death. As previously said, after cardiac death, we have got very limited number of organs or tissue. But if after donor after brainstem death, we may have the number of organs may be increased. So more emphasis is being given in the brainstem death in the Indian scenario, because we have the organ transplant rate in our country is quite less. And national level, we have got a national organization for transplant program, which is given the NOTO, that is a National Organ Transplant Tissue Organization, which is a nodal office which is situated in Delhi. Under this office, there are 5 regional centers in the 5 different cities located across the India. One is located in the Chennai, Mumbai, Kolkata, Chandigarh, and Guwahati. These centers are catering different states. They are like governing different state, and there's a name as State Organ and Tissue Transplant Organization. Then they are again further label like T is Transplant Center, R is where retrieval can be possible, and Tissue Bank or Biomaterial Center has been seen. So as stated earlier, regional organization will be states, and this is the broad functionaries of the regional transplant organization. This is what the NOTO is doing at the national level. This is regional ROTO is doing at the regional level, like networking, including allocation, where the SOTO, like state organization, is not functional. Coordination among the when the organ is allocated outside of the state. Collection of the data, statistic for maintenance of a registry, surveillance monitoring, training, taking workshop at frequent interval, developing academic or educational activities, technical guidance, providing a regional biomaterial center. These are one of the different functionaries of the ROTO organization. And this is the logo of the National Organ and Tissue Transplant Organization. As given now, coming to the why we are so reluctant to discuss the brainstem death in our community, or even if medical fraternity, because certain medical, social, religious controversies exist. Because if we say a patient, or we say the patient that patient is a brainstem death for any attendant relative, it is very difficult to them to understand, because they are saying the patient is having, though he's on the ventilator, the patient is having normal heart rate, the patient may having patient is showing oxygen saturation. If we touch the patient, that may feel warm. There is very difficult to convince them that the patient is like brain dead, or patient is so severely compromised that he will not survive. And there is a lack of uniform code across of the India. The different state has a different guidelines. There is usually no uniformity apart from apnea testing, and certain legal controversies. Say if we have carried apnea. If we carry apnea testing and the patient is not willing for organ donation, then what next we'll do? Should we continue the patient on mechanical ventilator till the patient will go in cardiorespiratory arrest, or will again frequent counseling with the patient, and to what extent we should extend? That is, there is nothing written in the law, and there are no specific straightforward guidelines. As we have got a certificate for cardiorespiratory, that we don't have any certificate for a brainstem death. Then there is another significant issue, because since the cardiovascular death, it is directly related for the acceptor for cremation, burial, or any insurance policies and all. There is nothing like any form apart from organ donation. Outside, there is nothing like a brain dead declaration form and all. And in Indian scenario, there's a definition of brainstem that has been given only in the transplant of human organ act. So what it has given a general impression, not only in the society as well as in the medical fraternity, that this brainstem death declaration is only in the context of organ donation. If you are if you are planning for organ donation, then only you will go for apnea test. So if we go to the attendant and if we discuss regarding brainstem death, they ultimately they Google it and they will take it that you are planning for organ donation. So there is a development of like lack of trust in the doctor or in the physician who is taking care of. Then coming to the how we should go forward regarding this, I think we should have go for extensive academic, educational, or knowledge percolation throughout the society. Which a lot of societies like Indian Society of Critical Care Medicine, various societies should come forward. They should take a lot of educational activity. They should enlighten the not only medical community as well as social communities. Now again, there should be delinking of the brain state with the organ donation. It should not be that if we are donating the organ, then only you should go for a brain stem death testing. Because in country we are lacking of the lacking of significant ICU bed resource limited settings. Ventilators are very limited. Manpower is very limited. We cannot keep on patients till even if we declare brainstem death, till the cardiorespiratory death has happened. There is might be wastage of resources, and it is said that treating a dying patient, it is not morally correct. Also, we don't have we have to form a uniform policy at national as well as state level, and we should include the brainstem death in the registration of birth and death act as it has been given in 1969. That after that we may think of outside both are different things, like organ donation as well as brainstem declaration, both are different things. We may think in that way. In in step towards this direction, government of Kerala in January 2020, they given a specific they given circular, they given government order that if the patient two apnea tests has been done and family members are not ready for organ donation, then with the consent of family, we can take off the cardiorespiratory support. We can discontinue the cardiorespiratory support. And once the brainstem death has been pronounced, here all the 4 panel members has to be signed and duly certified that the patient is brainstem death. And as already discussed, apart from Kerala, Gujarat is another state where they are following the same principle. They have recently proposed a government order saying that if the patient is brainstem death, which has 2 apnea test is positive, and it is certified by all the panelists, then you can discontinue the ventilator. But throughout the India, there is nothing like that. We have to again form a guidelines or something. Then this is always pledge for organ donation, because in our country there is significantly lack of organs, and terminally ill patients having end stage organ failures numbers are quite high. So we should pledge ourselves and will encourage our surrounding people as well as doctor as well as family member for donating organs. Thank you.
Thank you, Durgesh. Thank you, Durgesh, for giving us this overview. Ma'am, now I think we will take our expert opinion from Dr. Swarnalatha. Ma'am, over the last 1.5 decade or more than that, I've been a part of many intensive care units. Honestly, I should accept that there are still so many queries, so many doubts, so many questions in the fraternity of medicine. We'll come back to the community in the latter part, but in the medical fraternity, from our clinical teams who are treating the patient, there were so many doubts. So we will take one at a time and clarify those doubts, so that at least to the medical fraternity, things should be clear, so that we can communicate these issues when these have been raised to us from the families. Ma'am, the first query is, Suppose we face a patient whose brainstem reflexes are absent on our clinical examination. For example, during our examination, we found the patient has no spontaneous breathing efforts, no gag reflex, no any other respiratory stimuli related responses, and pupils are dilated and fixed. And we have done a calorie test, which is also looks negative for any brainstem function. So in these situations, so when we go for an apnea test, which we understand very well that we have a form from Government of Telangana, the Cadaver Transplant Act, which is giving a form that again comes with a word called transplantation, if you see on the top of it. So in this context, when I proceed for an apnea to confirm my patient's brainstem reflexes, creating a carbon dioxide pressure of almost a rise of 20 or more than 60, which we believe the strongest stimuli for a brainstem to give a breath. In those situations, when I attempt for an apnea test, do we really need to go back to the family and talk to them about it, that the patient has no brainstem reflex and needs an apnea test to confirm? Or what is the take which you should give us and clear our ideas? Because many of the times we get stuck at that point when we don't have a brainstem reflex and we need an apnea test, we get stuck. Please and elaborate on that.
Yeah, first of all, I should congratulate your team for having selected this sensitive topic and try to enrich your knowledge and update your knowledge. So, like, I have been handling this project at least for last 1 decade, and I have seen various stages of evolution of this organ transplantation program, particularly with respect to deceased donor. So, and I really appreciate the Yashoda group of hospitals for transforming themselves. In the initial stage when I took this project, I know how resistant the hospitals were to even talk about the brain death and organ transplantation. So now they have actually traveled almost 180 degrees, and now Yashoda has evolved as one of the biggest hospital for the organ transplantation, not only in Telangana but across the India. And we see patients being transplanted, organs being flown from other parts of the state and being airlifting the organs and getting transplantation in our state, particularly Yashoda Hospital. So I really appreciate the Yashoda Hospital for having evolved as a major player in organ transplantation program. And coming to statistics, I think we have done around 897 donations so far. From the year of the commencement of this program in 2013, and around 3,000 organ transplantation. And Yashoda has contributed almost 25%. Yashoda has done around 247 donations in all the three, including all the three branches, with around 206 kidney transplants and 226 liver transplants, 16 heart transplants, 22 lung transplants, and 1 pancreas transplantation. Overall, they have done 471 organ transplantations. So I really appreciate that. Second thing, I really appreciate Dr. Durgesh for having covered this organ transplantation right from the brain death, cardiorespiratory definition of brain death, then coming to a brain death, then talking about how the act has evolved. In fact, it's very difficult for even for a transplant, as a transplant physician surgeon, to understand the act. So very, perfectly only reflected the important points, which is important for as a clinicians or as intensivists. So you have been clearly elaborated the act point of you also, and subsequently you have covered all how it's evolving in at a national level through NOTO, and at a the state level, that is Jeevandan. So I really appreciate for that, sir. So coming to your point, we face a situation where we know that it is a brain death. We know this all brainstem reflexes are absent. And the only confirmatory test, as has been elaborated by Dr. Durgesh, is the apnea test. The apnea test is the clinical test where we can confirm the brain death. But then, do we have to take a consent? So we did have these dilemmas when we began this program. But this is like any other clinical test, is only a bedside simple clinical test. Doesn't require any sophisticated lab or something like imagiology, something like that. So we don't have to have any consent for a performance of this apnea test. So we can actually go ahead, but it's like, you have to prime the patient, give the prognosticate the patient. That patient is not doing well, he's going to a stage of probably a brain death, and probably for confirmation we need to do test, and we are doing that. But consent as such, written consent as we take for any of the procedures, that is not required.
So, ma'am, suppose we assume that this will be a part of our clinical examination and clinical test like other brainstem reflexes, and we go ahead and do this apnea test with probably what we are doing right now is informed consent. We are informing the family that this is his condition, his reflexes looks absent. We are doing a confirmatory test to confirm these things. And that will be probably regarded as your first apnea test when we do this test and come out with a state that the first apnea test is positive and the patient's brainstem reflexes at that point of time are absent, and you need another test in maybe a gap of 6 hours by 4 expert panels. Now the question is, you go back to the family, and now is this the point where we talk about the brainstem reflexes absent and we need to confirm it after 6 hours? And what if the family comes back and says that no, we do not believe these tests, and we still see there is a lot of emotions, social and religious beliefs in Indian context. I have been seeing this thing for the last 15-20 years. Most of our patients who go to brain dead are from trauma or a acute massive stroke causing this catastrophic event. So most of the families are in tremendous is a situation where they've been under a lot of trauma, mental, psychological, emotional trauma. They are not able to digest, trust, or believe that the patient is gone into a state of irreversible coma or into a state of brain dead. In those situations, what is your take legally and standpoint in the context of first apnea positive family not able to digest or take that the patient is brain dead or patient brainstem reflexes are absent?
Basically, as you have rightly said, the patient will be in a lot of grief. Particularly, most of the time brain death happens in a young patients with the road traffic accidents. So definitely there will be a lot of grief. It's very sensitive subject, and it has to be done in a stages. It's not like once we do a apnea test, you go to the patient's family member and say patient is dead. So it has to be handled very gently and in a staged manner. So again, I want to re-emphasize, it has been actually been emphasized by Dr. Durgesh also, that we have to de-link the brain death from the organ donation. It's not like brain death is always an organ donation. So that we have to inculcate. In fact, as it has been said by Dr. Durgesh, that even the declaration form, brain death declaration form, which is form number 8, has carries that organ transplantation. So actually, what I want to emphasize here is that you have to de-link the organ donation from the brain death declaration. So actually, you don't have to directly go and start putting everything on the form 8, which is the brain death declaration form. You have to first declaration we have to document in the case sheet, the routine case sheet which we document patient's clinical development. So we can document the first apnea test there, and you don't have to take consent. Subsequently, you engage a counselor. It's also been mentioned in the latest the amendment of the act that the counselor is mandatory. So every ICU should have a counselor. And not only they're not always talking only for the organ donation. Otherwise, also they should have something like support system, giving a support, emotional support, or at the time of grief. So they should be attached at that level, trying to give support to the family members, trying to let them out of that grief. So once they get a confidence, then slowly after first declaration, because now brain death is little confirmed, then you can start about make them comfortable, talk to them, try to understand their mental status, try to understand how's their education, understanding capacity, their education capacity. Can they accept organ donation? Do they know what is brain death? And then you understand. Initial few sittings should be for understanding their the mind and their the level of understanding, and then providing them the comfort. Once this is done, then slowly you start the conversion about the eye donation. As you know, that eye donation has started much before the organ donation. So they might not accept the organ donation. Slowly you have to make them aware about the corneal donations. Once they understand this and accept, then slowly probably you can push them for or I'm sorry to use the push them, you don't have to push them, you can make them understand the whole process and start talking about the organ donation. So it is a slow process. It is, try to in a multiple stage. So we can't, reveal the death, all of a sudden to the family members. Yes.
Yeah, I do got that point, ma'am. But most of the times the dilemma is your first apnea is positive, and we go back and tell them the patient as you said, in all possible care that this is the patient's condition where we are not able to get any reflexes in spite of the last test, which we say the apnea test. But we again go back and tell them that we need another test to confirm it. So they still, I have seen practically that they still feel a hope that, okay, this is not the confirmation, you need to reconfirm it, another test at 6 hours. So our point is, till we do a second apnea test, we say them, we are done a first apnea, which is positive, but we still have to do a second apnea. And that only will confirm that whether the patient is brain dead or not. So this is the time where we were in dilemma that should that be a point where we talk about organ donation, or as for the act, once you delink, you declare brain dead, that is different, organ donation is different. So that means first you have to confirm that the patient is brain dead. So what will be the right point where we should be discussing about the brain dead?
It's again a gray area. As you said, it's, it's very difficult, and, where to start the counseling about the organization is again a gray area. There's nothing has been mentioned even in the act also. But as you said, it's a process. Like, first declaration and then second declaration is like after 6 hours. It's a process. So we can try to start counseling them, start, understanding them, and then slowly towards the second declaration, you can actually talk to them about the organ donation. We can tell them that it's brain dead, but for the declaration, we need to have another test to be sure that he's not, he's completely dead, is even not in a single 0.001% chances of, the recovery. So we have to slowly can start after the first declaration. And after the second declaration, most of the time it's patient will be unstable. As you know, it's a very dynamic process, and we need to, optimize the organs also. And the whole process of organ donation is the organ should be viable. And once it is transplanted to the recipients, the patient should have a good quality of life. So we, as a transplant, program, so we are also concerned about the viability of the organs and the outcome of the same organ in the graft in the recipient. So optimization is also very important. Once the second declaration is done, what we have realized is the patient does, family members does agree for organ donation, but there's a lot of time is required for the processing of the whole issue, basically for optimization of the donor, and then completing the legal procedure, patient is medical legal, then sending the alert to the other hospitals or as per our local allocation policy guidelines, and getting the patients to the hospital preparing. This takes a lot of process. And most of the time, what happens is once they give a consent, they are honey because they know patient is no more. So we are trying to prolonging their grief. So we want to cut down all those process. It is difficult for the family members to go through all this process, and it is difficult within a limited time to organize everything. So we start practically, after first declaration, we start the council of organ donation, family members for the organ donation. And once they have some, acceptance, and we start the legal procedures only after second. So we can start the counseling part, but whatever is documentation is there, particularly documentation in a Form 8, the brain dead declaration. All this legal documentation starts only after the second declaration. Okay. But counseling can be started at the first declaration, after the first declaration.
Yeah, the contact and follow up, and as you say, there will be a lot of logistical challenge can be considered as in the first part in contacting the families and patients.
Yes.
Yeah, but the second part will be, ma'am, suppose in this part, the family blankly refuses any form of consideration of organ donation.
Yes.
There our challenges double up. So what is your take in those situations?
So from the beginning, our concept is delink. If they don't start the counseling, if they deny, they accept it, do not pressurize them. And as I said, legal documentation starts only after second declaration. You have to document clinical, whatever is clinical finding properly in a case sheet, because case sheet is also actually a legal document. So you can document the first declaration, time of the first declaration, whatever test, brain test, reflexes you have performed, the apnea test, including the ABGs, both the ABGs you can document case sheet properly. Okay. And then second declaration also, you can go for a second declaration and the, the legal documentation part in a form 8 and form 6, that is the consent form, only after they accept and we do a second declaration. Actually, you can second declaration we can do because we are not concerned about the organ donation. We can put it in the case sheet that for time of second declaration, we can leave it at that time. We don't have to go for an organ donation, but we have to document that patient has been, or family members have been offered the possibility of organ donation. They have been explained and what is their take on that. They are accepting, they are not accepting. We can formally document in the case sheet and leave it. So that the patient is allowed, but patient has, means their wish, family members, they can, go for organ donation, they can deny also. And once they deny, we have to respect their decision and we have to go accordingly.
Yeah, so what I understand is you continue your process of brain dead declaration as given by the law. After your first apnea, give a gap of 6 hours, irrespective of the family, whether they are willing for organ donation or not. Go for second apnea and document on the case sheet. No need to document on a Jeevandan or form of a transplant act. That's what you mean to say, ma'am.
Exactly. Okay. Documentation need not be followed.
Yes.
And it's not Jeevandan. Actually, these forms have been taken from the Act. Act very well defines. They have different forms are there for the consent forms, organ declaration forms. We have a consent if there are no, the family members, kith and kins are not there. His patient is, unclaimed, the brain dead person. So there's different forms are there. So we are using the same forms. We are not modified anything of it.
So now we de-link and first we go ahead and say ki the patient is brain dead or not. If a patient is brain dead, declare as his normal flow. And then if the family is willing for organ donation, that flow will go for organ donation. If now the patient is not willing for organ donation, you continue the existing treatment. Now the second complexity starts, ma'am. When you say a brain death in your case sheet, for all legal reasons, the patient is dead. Am I right?
Yes, exactly. That's what I said. Once you have declared second declaration time and date is the time of death.
Okay. Now the patient family says we refuse for organs. And now the next course of actions, how do a clinician should react to that?
Yes. So now this is how the challenge is. First challenge is acceptance of the organ donor. It's fine. It's accepted. It's good. Like, we'll go proceed for organ donation. It's not accepting, and we have documented in a case there's a brain death. So there's a second set of challenge, as I said. So here there is again a gray area. So as per the Act, we are not allowed to discontinue the legal support system, life support system. But recently, two states have come up with a local GO saying that if patient has been declared brain dead and they have all the 4 doctors who have declared as has been mentioned by Dr. Durgesh, that they have a panel of 4 doctors. The 4 doctors, they have to approach the family members. They have to counsel them about the family, their brain death. And if they don't agree, they can actually, and then they have mentioned that it's not can be, it's must be. So they have used that term must be. So they have given that, possibility of removing the life support after they deny organ donation. And then the organ brain death has been declared. So that is there only in Kerala, and that has come recently in Jan 2020, just before the lockdown, this COVID, and then subsequently by Gujarat. So, but I don't know practically, maybe I try to talk to them, but practically it's not possible because again, the concept of euthanasia. So because we are not legally allowed to discontinue, isn't it? But if you look at the Western countries, because of shortage, they are allowed to do that. But in India, though the government has come up with the GO, but it is not been practiced so frequent because there is some apprehension still in the minds of the hospital doctors or the hospital administration. So if they, particularly when the family member says they still want to continue all the support, as a doctor or from medical fraternity, so we what we can take care is we have to document everything that patient have been given the option of organ donation. They have declined, so patient is dead as per the brain death the Act. Patient is brain dead and the life support is being continued as per the patient wishes. That have to be clearly documented and has to be properly the signatures have to be taken from the family members.
Yeah. Now the second challenge comes, ma'am. Now you have declared this patient dead as per your brain stem declaration or brain dead declaration status by second apnea, and you're waiting for a cardiac death to happen. Am I right, ma'am?
Yes.
So now after a week, after 10 days, after 2 months, after 3 months, the patient still on a ventilator with all supportive care dies after 3 months. Which will be your death date? Which will be your death time? Is it the second apnea time or the cardiac death time?
No. So as per the agreement, fortunately this has not happened so far. So even if they have not agreed, it was maximum a day or two. We have not seen in even a week's duration. So it was maximum hours to days only. So fortunately we haven't seen. But as you said, we can definitely, in future come across. So situation should be prepared for that.
Ma'am, we have come across 2 weeks, 3 weeks.
3 weeks. Okay, fine.
Good critical care.
Okay, so it all depends upon your capability of managing the patient in ICU. So now we have to take a second, because we have officially documented. The second is the declaration. The second declaration of the brain death is the time of death. So we have to put that only as a time of death, and the present is the cardiac death. So when we issue a patient, the death certificate, because for all practical purposes, we considered only the cardiac death. So we have to issue that time of cardiac death as a time of death.
Yeah, that's what we don't have a form for brain death, except the Transplantation Act. We don't have a separate form when we actually declare a death in a patient in out of the context of transplant. Our forms doesn't contain the brain death component. It will be like again.
Having brought out this point, I would like to just discuss that we did have a meeting with all the officials of the government. We stated that the certificate should be modified. Every the cardiac death, how we write what is the immediate cause of death, what is the underlying cause of death. So we should also include a point that whether the main patient had a brain death, and when did they had a brain death, what was the time of declaration, and if so, we have to document all those other findings, so that every death we have a concept of brain death. It will bring awareness about the brain death amongst the medical fraternity, and also it will solve the issues like what you have pointed out. So that's if we can always have a brain death that time and the cardiac death time. And this we have suggested, but I don't know how far it will be implemented. So we have discussed at the state level as well as national level, but there are a lot of controversies. As you said, one or two cases, it becomes a controversy. They want to look at it as a 99% by and large. So they want to go for that rather than concentrating on 1 or 2%. But I think these are practical issues. And in future, if we come across more and more issues like patient, because better after this COVID, I think all hospitals, they have a better ICU management. They have their own ventilators, their own ICUs, and their own expertise team. So probably we might come across in future, and then if more when comes up in the future, probably we need to think seriously about it.
Yeah, ma'am, we have actually challenges in families where even it is rare, so there will be some advanced directives from a particular patient or a particular person in advance, which is not very common but many of them they pledge. Now again, come to the situation where the family has a refusal, or sometimes we also face a situation where a few of the family are okay to donate and others has objections. So these must be a common situations to you. How you handle them?
Yeah, these are very common situation in India, particularly because the legalities in India is different from what we see in West. West is organ pledging is legally valid. So one particularly they represent in the form of a driving license. They have different color codes. Once in patient is admitted in the hospital, they see that organ donor card or the driving license card if the patient has pledged. So we don't have to take consent from any of the family members. So they directly go for organ donation. When few of the European countries opt out by default, the citizen is an organ donor. So they don't have to look for whether patient has pledged for organ donation or not. Coming to India, it is different. Organ donation is only means of creating an awareness. Once patient has, the person has pledged for organs, and as of now, we haven't come across a situation where patient is admitted with a brain death, and we have known that patient is already pledged for organ donation. So, but then even if patient has pledged for organ donation, we have to take a consent from the family members after brain death only. So that is only a legally valid document for a consent for an organ donation. So even though patient has pledged, the family member says no, so that's an absolute no, we can't go for organ donation. The second point, what you said is definitely there are maybe in India we see the joint families. And even if they're nuclear family, when they come across such a major situation where decision making is important, they always take opinions from the other family members. So we do come across where most of the time one family member is agreeing and the other is not agreeing. So in that case, we have to go for the opinion of the person who is next, who is in legal position of that particular patient. Particularly, it can be parents, it can be siblings, or it can be the kids, or it can be spousal. Whereas the immediate near relative, he is only allowed to give consent. If he says no, usually we don't go for organ donation. If says yes, then it has to follow the proper legal document they have to sign. And again, we look for the witnesses also. So that is an issue. And sometimes what happens is, practically what we see is, particularly when a husband is dead, wife is supposed to be a very weak in decision making. So wife, she cannot take a decision making. She always goes for the opinions for the others. So in that case, even though the female, that the wife is strong and she wants to donate, she gets influenced by others. And if she says no, we should go for organ donation. That's one situation. And second situation is when the wife is dead, husband is willing, but again there are certain situations why they are the parents of that wife.
Yes.
They take it as a some suspicion that it could be some suspicion. They look at the death as a suspicion. So in that case, even though the husband agrees, so the parents of that the wife, the brain death patient, so they are in a dilemma. They don't agree. So we take, though legally if the husband says yes, we can proceed, but we take an extra precautions. We talk to the parents also, and if they agree, we take it as a witness, and then they proceed. I just want to share one situation, the case which we have dealt almost 3-4 years back, where wife, they got recently married. It was just few years, and wife, she fell in the bathroom unconscious, and then she was brought to the hospital, and she was declared brain dead. And the husband, family members of that lady, they put a case against the husband saying it's a dowry death. And both the family members, they believe. The husband thought probably after the organ donation, the whole process, legal process will come, the legal charge, whatever is the charges, he can get rid of that. But again, it was a little tricky situation. So we counsel both the families, the parents and the in-laws. We have taken consent from both, all of them, including the parents, the husband, and the parents of that husband also. Saying that, with organ donation, he cannot be denied of any of the charges that will follow as per whatever is the legal procedure. And we have taken all those consent. And the patient, that lady was shifted to OT for organ retrieval, and the husband and the family members of the husband were put in jail. So this was a situation we encountered. And then we had to, and this becomes a dowry death. For the dowry death, it's not the police who has to do the inquest, it is the magistrate who has to do the inquest. So we had to call the magistrate, and we had to organize a post-mortem. We have done a complete post-mortem so that in future we don't come across any of the legalities of this. The husbands, they were prosecuted, and subsequently case is resolved. So whatever, so it was just a suspicious. She really fell in the bathroom. Okay. So it's been now 3-4 years now. There are no legal issues. This was one which I was little skeptical about it, but everything went on right, and then it's been now 2-3 years with no major.
There were some queries related to ancillary tests, like what we discussed about situations where we can't do a proper brainstem reflexes when you have facial injuries, orbital injuries, hemodynamic instabilities, sick critically group of patients and all. And all of us has a practice of doing ancillary test in those situations, mentioning about inability of brainstem testing. Including 4 vessel cerebral angio or a transcranial Doppler and all that stuff. Ma'am, what is your take? See, we don't have any legal point or stand on that. None of them mention about it anyway. So how do you take them in this context?
Act is just a broad outline. So act is followed by, just want to mention the process of the legal documentation or legal, process. First is the act. Act will only mention the outline of whatever is the process. Second is the rules. Rules will constitute how to go about it, the process of how to go about it. Then comes the guidelines. and then comes the recommendations. Recommendations are by the scientific committee. These are the legal processes. So Act may not mention that, but we have to ensure that in rules or otherwise in GOs, we can come out with all this clarity. So Act, they have broadly said, the apnea test, and then they left it at that point. But most of the states, what they have done is they have put it in the GO, stating that these are the ancillary tests. If apnea test cannot be done, we can go with an ancillary test. And this has been particularly mentioned now in latest GO of the Kerala, and then Tamil Nadu, and then Gujarat. And it's there in our Jeevandan GO.
So we have our Jeevandan GO, which also states the ancillary test as a legal stand.
Yes.
So it means that legally we are stand right like any apnea test. When we are not able to do apnea test or the brainstem functions, we can do any of these ancillary tests and confirm that.
But I mean, they are only the confirmatory clinical test is the apnea. If we are able to do apnea, you proceed with the apnea. But in situations where we cannot go with apnea, particularly with facial injuries or chest injuries, or patient is going to hypotension or hypoxia with the discontinuation of the ventilator during the process, then only you can go for an ancillary test.
There is another point in ancillary test, ma'am, when there is actually a difference in opinion among these 4 clinicians that the patient's apnea test is positive or not, then also ancillary test may come into play.
Yes. And the panel of doctors are not agreeing to apnea, the results of the apnea. Usually what happens is, that's why we have to look for the both the apnea by the first and second ABGs. So we have to document it is not like it's subjective, it is objective. We have to demonstrate that it is 20 millimeter rise in the PCO2 after the first ABG and second ABG. So if that is clear, it's fine. But if if we can't wait till that is built, PCO2 is built, or patient is going to hypotension, usually disparity comes during the process, not the results. The results are there, it's fine. The process, we can't wait for such a long time. Only then, usually the disparity between the the consensus of the declaration comes with the procedure. So if they have a doubt, they can go for ancillary tests.
Ma'am, what is the take of a pediatric age group? As Dr. Durgesh pointed out, the gap in apnea test varies and all that, and even in hypothermia also situation context, the duration to optimize the temperature and do is vary. So what is your take and experience in pediatric age group, ma'am?
Yes, definitely, because 6 hours is basically to confirm that there is no chances of recovery. That is a minimum period, because that is how the time period where the brain can recover. But if you go to a younger age group or pediatric age groups, they are so they are more flexible. So what happens is the chances of recovery is very high in pediatrics. That's why the duration has been increased to 12 years for the patients like below 18 years. Above 18 years, adult is 6 hours. Below 18 years to 1 year, it is somewhere between 24 hours. When younger the patient, more flexibility and more is the chances of recovery. So more is the duration between the first and second declaration. Infants, we go for a 48 hours. And then in the neonates, we go for even like 1 week. So we can't declare brain death immediately after birth. We have to at least wait for 1 week before we declare a brain death. So youngest age group, what we have found is 8 years, where we have waited for the 12 hours for the declaration of the brain death. And in fact, we do now recently, we have tried to motivate the Nidofer hospital. We do come across few calls where the patient with birth defects, particularly neural birth defects, they can become an organ donor. So there we have to wait for at least for 1 week before we try to declare as a brain death.
Yeah, Dr. Durgesh, I think you have been a spectator. I think we all been a spectator when the experience, the knowledge, the wisdom of Dr. Swarnalatha speaks. But there are questions to you. We know there has been a controversy related to this hormone supplementation during the management of this brain dead patients, donors, which we talk about mean arterial pressure, a temperature, a sodium levels, blah, blah, and we supplement some of the hormones. So you have pointed out one of the areas along with the thyroxine. You made a comment of methylprednisolone in such a high dose of 15 milligram per kg. So there were question, is it required in all patients, or what is your comment on that? I do understand there are various opinions, different protocols, different guidelines across different countries, and it varies institute to institute also, Dr. Durgesh.
Actually, methylprednisolone is to be given when you are planning to donate lungs, especially. Otherwise, it has been given in the guidelines that actually we start anyway. When you will start from the optimizing a patient who is supposed for a brain death or that, we'll first start with a steroid, hydrocortisone particularly. We'll give it the stress dose of hydrocortisone. Then again, if we want to start like lungs are also in the list of organ donation. The patients are having like no significant pulmonary edema, and he can be a lung donor also. In that situation, we'll give a methylprednisolone in the high doses, like a 15 milligram per kg for in the 24 hours. Otherwise, we don't give methylprednisolone in such high doses. So if we are like maintaining, it is like only maintenance of organ is more important, where suppose
so what will be your priorities, Durgesh, when it comes to the organ or a donor management?
Like first priority will be our mean arterial pressure maintenance and maintenance of the oxygen saturation, like etc., like more than 94%, or mean arterial systolic blood pressure of more than 100 millimeters of Hg. That is our main priority. Later on, that when the vasopressin, depending upon the incidence of diabetes insipidus and all that, hormonal replacement therapy will come, because there is suddenly there is like pituitary is not functioning, cortisol levels are not there, there's severe vasoplegia, and moreover that the catecholamine response is quite less. Here, for that purpose, initially we should start with the hydrocortisone. If like we are contemplating the lungs as a transplant organ, there also we can start a high dose of methylprednisolone.
Okay, now so to maintain a cellular homeostasis, you wanted a mean arterial pressure, good oxygen, good glycemic control, good metabolic control, and you try to maintain the cellular homeostasis as normal, as close to as normal.
Yes.
Any comments on the controversies? You have been a part of this, the management of organ donations and this patients management. You must have been faced many challenges. Any comments or questions to Dr. Swarnalatha?
Like sir, as discussed, like whenever we are approaching any patient, like attendants are approaching, like as pointed out by madam, we should we should go stepwise manner regarding that. Initially, declaring the how the critical the patient is, how the support will require, and what are the current injury status, like how severe is a brain injury, and what what we are taking care. First, first anywhere we are doing, like first our priority should be like first is saving at any point of time. Then if at all the patient proceeds and he land up in a state where the progressive, there is a coning or there are absent of brainstem reflexes, then we have to do a frequent counseling. We have to take attendant in the confidence that, and this what is the current situation happening, then how we should go forward. Then the frequent counseling, there should be development of rapport between the ICU people or any consultant who is taking care of the patient and the attendant. Once the rapport has been developed, when the trust has been built, then we can involve more them than the counseling. Initially, after suppose that is all the brainstem reflexes are absent, all we rule out any confounding factors. Then we'll again counsel a patient regarding there are chances are brain death is there, which is legally and clinically is a valid option. Then again we have to give a time them to digest the thing. Most of the time, what I heard is many of the people they search Google, and many of the people they search their any relative which is staying abroad, and they said that even if we utter a terminology like brain death declaration, they'll take in the context that the organ donations might be planned. That we have to again dealing the process here.
Okay.
Yeah. Then again, like after 6 hours, then it is like our like to confirm it, like it is to make sure we are planning for a second apnea testing. And after that only, and the thing is that whenever you are counseling, when the two apnea test has happened and the apnea test is positive, then only that probably organ donation thing should come. And it to like maximum time, it should become from the attendant. If by law and by so who was taking care of the patient, they should not utter what regarding transplantation. There are different transplant coordinator, different they should be handling the different issues. Where will our role should be like limited to the certification of brain death with the two like apnea test separated by 6 hours.
Okay, I think he has made a valid point, ma'am. Most of the time the issue is with the trust, the belief, and the rapport when with the clinician to the family. So if the family is completely in confidence that the treating team is focusing on making the patient better and making this patient survive, making the patient to come out of that traumatic situation, then in spite of all these efforts, the patient is not making any progress. If they are in that loop of follow-up, then it will be easy for them to take into the next step of telling them about that. So initially, when we actually approach them, we should be talking to them about your efforts to make the patient better. And if they are in complete align with you about and completely in trust with you that the patient has been getting the best of care to make him out of that difficult situation, then it will be. Ma'am, there are some questions. We'll take. Every hospital has a priority organ being allocated to them. Kidney, once they are declared a brain dead patient, do the family also have a right to recommend for an organ for their own kin and relatives? This has been again a common doubt, ma'am.
Yes, in fact, whenever we counsel, so I mean, three things I wanted to say before I go to your questions. Is one is, I mean, continuous counseling just before the brain death. That is counseling, particularly with respect to the putting the facts. You should not give that patient is doing well and suddenly after death you just change your conversations. Your version saying that patient is now dead. So putting the facts before them, counseling much before the organ donation, and after brain death, slow approach. These three are the important key for the success. And second, what you said is definitely most of the donation, they come with this is called directed donation. They come with a fact that yes, we agree for organ donation. Now in fact there is a change in the public attitude. So initial days when I took this project, 10 years before, there a lot of resistance was there. Now that everything is, I mean, we are talking about in the public media and various social media, people have started accepting. Now the acceptance rate is very like high. But then they say we have our own family friend who is suffering from kidney disease. We would love to give it to them, or we have some family members or friends or something like that. We know some person. But again, the whole process of this, when the program and then Jeevandan program is to have a unbiased organ allocation, to have equitable distribution. Now the main purpose is to cut down the commercial dealing of the organs, isn't it? So to remove that bias, only this program has come. So again, we can't entertain the directed donation. So from our side, it's absolutely clear that patient organs will be allocated as per the protocol. And now the first thing what we have done after this program was to create a transparent online organ allocation. And there's a committee, as you know, we have committees for everything, and then we have committees have come up with the recommendations, guidelines. We have transformed that to a online allocation process. So we make it very clear that it should, organs will be allocated as per our own allocation policy, which is online. It is transparent. It can never ever be given as a directed donation.
Thank you, ma'am. I think with the restriction of time, I think we thank both Dr. Swarnalatha ma'am, who has been our guest panelist today, explaining and probably clearing many of the doubts which we all had. And I also thank Dr. Durgesh for his eloquent presentation and points. I thank all the participants and who have participated and spent their time in interacting with all of us. And with this, we do understand we need many patients who are waiting for organs in the last maybe 2-3 decades, and a good reason Dr. Swarnalatha and the whole Jeevandan team in the state of Telangana has taken up well. And a good part, as he mentioned, that the Yashoda group, as we have been very fortunate to be a part of it, where we have seen 400-500 patients getting transplanted, including the lung, heart, and other organs, which has been a routine practice like renal transplant and liver transplant, which we have seen in our own unit, who will be walking out happily, spending their time with the family, coming back with the flowers and cookies to all the treating team there. This will be an amazing experience to actually treat to our eyes. So which we all started believing now that all these organs which are wasted, all healthy young organs which are just wasted in the past, will be in use, ma'am. Thank you for your time and availability. We really appreciate all your efforts and Jeevandan team's efforts, and the team of Jeevandan in the state of Telangana, ma'am. Thank you so much.
Thank you, sir. It's my thank you. I mean, I have learned a lot of things. I mean, from you all. It's been a very dedicated team, and I enjoyed this session. And I wish that you continue your services and your organ transplantation program like this in future.
Thank you. Thank you. Thank you, Durgesh.
Thank you,
Thank you all the participants.
Thank you, sir. मेरा आया कि नहीं जब मैं बोल रहा था सर ऑनलाइन आया कि नहीं मेरा आया सर उनको पास रहता सर कंट्रोल के पास हाँ कंट्रोल जो नहीं तो इधर को डिस्ट्रिक्ट